And there we go. Nothing worse than starting a Zoom session and forgetting to record. Then you end up having to do the whole bing-dong thing over again. All right. Anyway, last week we were in Unit 3 and we covered the middle ear. We went over the pieces and parts and the anatomy of the middle ear. And then we talked a little bit about the physiology of the middle ear and why we have a middle ear in the first place. In other words, airborne sound would bounce off the inner ear because the inner ear is filled with fluid, the cochlea. It's filled with fluid. And airborne sound is going to bounce off the water. If you were swimming under the swimming or in a swimming pool and I was talking to you from outside the pool, my voice would bounce off the water, wouldn't it? You wouldn't hear a word I said. Well, that's why you've got a middle ear. And we'll just quickly review that and then move on. Okay, I will share screen and show you the PowerPoint slide that we talked about this. And we said that the middle ear increases sound pressure in 3 different ways. And it does so because the size of the drum, as you can see here, is so much larger than the footplate of the stapes. And I think I had you last week. We put our hand to our face, and we did this in acoustics this morning too. If you put your hand to your face and push hard, you haven't got much pressure. But you put your finger to your face and push hard, and it hurts. That's why you got a middle ear, because it increases the pressure of airborne sound so it can activate a fluid-filled cochlea. Very important concept to understand, yeah. So we've got the 3 ways that the middle ear does this, and we went over this last week's Zoom session. If I carry on and move to the next slide, okay. And, no, not that way, but go this way. There you go. There's the size of the eardrum relative to the size of the footplate of the oval window. So pressure is force over an area. That's numero uno. That's the first way. And the second, you can see it here too, the eardrum is way larger than the footplate of the stapes. That's the main way in which the middle ear increases pressure. The second way is the fact that this manubrium of the malleus bone is a little bit longer than the incus bone. And much like a teeter-totter or a seesaw, here you can see the same. This is a little bit longer than the incus bone. And so you can think about like my 2 arms, and I'll stop sharing for just a second. One arm is a little bit longer than the other arm, and that's going to increase the pressure, just like when you go to the park with a child and you give the child the longer end of the teeter-totter or seesaw to even things out. Just like a lever, the longer handle gives you the advantage, okay? And that's the same reason why you have the little bones of the middle ear. One is a little bit longer than the other one. And thus what it increases, here you go, the longer handle versus the incus, you've increased the pressure by a factor of 1.3 to 1. And then you have the eardrum itself, which buckles, doesn't move all the same. It kind of, you can see that this part here moves more than the umbo and more than the edges. And that's the third way. And that increases the sound pressure by a factor of 2 to 1. So when you put all these together, you've got a pressure increase of 44 to 1. And what does that correspond to in decibels? And people who heard the 110 session this morning, you'll be able to piece some of this together. Because when you increase the pressure by 10-fold, you've gone up 20 dB. Increase the pressure 100-fold, you've gone up 40. Well, last time I looked, 44 to 1 is somewhere between 10 to 1 and 100 to 1. Work out the math, which we won't. It means that the middle ear makes up about 30 to 35 dB. That's why you've got a middle ear. And we'll even mention a tuning fork test called the Retina tuning fork test, R-I-N-N-E. It's in your notes. And I believe what I'll do is I'll show the screen here so we can see those notes as well. And if you're scrolling, look at this. The physiology of the middle ear is what I'm highlighting here. And then you look at this Retina tuning fork test, and that's just dinging the tuning fork, holding it, put your hand against your finger against the bone behind your ear. So if you put your finger behind that bone, that's your mastoid bone, that round bone. So what they do is they ding a tuning fork, and they'll put it against that bone, and you'll hear it through the bone, but then they'll pull it away and hold it by your ear. Whoa, that was louder. So without the middle ear, with the middle ear. Without the middle ear, with. Because sound going through the air is going to go through the middle ear, whereas sound going through the bone ain't. So bone-conducted sound will sound not as loud as air-conducted sound. And that difference, that extra loudness you hear that way, is a wonderful example, an experiential proof of what the middle ear is adding to input sounds, 30 to 35 decibels, thus enabling airborne sound to activate a fluid-filled cochlea, the reason why you got a middle ear. So we went last week and we talked about the middle ear overcomes this impedance mismatch. The word impedance mismatch is simply the difference between air and water. Okay, impedance mismatch is an important word. It's the opposition offered due to the fluid-filled cochlea. Airborne sound hitting a pool. Hey, if you jump off the side of the pool and do a belly flop, it's going to hurt, right? That's an impedance mismatch. Okay, you're falling through the air and suddenly, wham, you hit the water. Impedance opposition mismatch. And the middle ear does this in 1, 2, 3 ways. So I will hint for you and give you a heads up. Expect to see this kind of stuff on quizzes and midterms. This is a kind of question I will be asking because the HIS needs to have a good idea as to why you have a middle ear in the first place. Okay? Most people don't think about it, but it's our profession. We need to know these things. Okay, big events. Let's scroll down. Now you're going to see something. I'm not sure how many of you, of the 4 of us here, how many of you are taking 130, Introduction to Audiometry? You are, Shabana? Okay, great. You know what you're going to learn? You are going to learn later on, I'm not sure if you already have or not, you're taking Anatomy 120, and Audiometry 130. A conductive hearing loss is when you've got difficulty with the outer or middle ears, right? Something's blocking the passage of sound from getting to where it's got to go. And where does it got to go? To the inner ear or cochlea. So excess wax, yep, conductive hearing loss. Middle ear problems, conductive hearing loss, okay? Now the conductive hearing loss means problems with airborne sound, but not problems hearing by bone conduction. Okay? So children with earaches will have a hearing loss through headphones, but when you take the headphones off and you place a headband with a little box sitting on the mastoid bone and deliver the sound that way, the child hears like a baby. And so the audiologist or doctor or HIS goes, yep, no problem with the inner ear. Good, because you can't fix that. That's hair cell damage. Can't fix it. But middle ear pathology, yep, the kid hears perfectly normal through the bone. Problems hearing through the headphone means middle or outer ear infection. Can be fixed. Okay, that's called a conductive hearing loss. Unfortunately, only 5% of hearing loss in the world is conductive. Most hearing loss is sensory neural or due to inner ear pathology. So anyway, here you go. Maximum, read this, the maximum conductive hearing loss possible to measure is more than what the middle ear makes up. We said the middle ear makes up 30 to 35 dB. Here it says 20 to 30 dB. no matter. What's 5 among friends? That's not the issue. The issue is this. If the middle ear makes up 30 to 35 dB, then why is maximum conductive hearing loss more than this? In other words, when you measure under headphones, you can get a 60 decibel conductive hearing loss. Well, if the middle ear makes up 30 to 35, how come your conductive hearing loss can be worse than that? And here's why. Something to consider. Okay? Here you go. If the middle ear normally makes up some 30 to 35 decibels, then why can a conductive hearing loss be more than this? Here's why. Ordinarily, and I'll make the picture bigger here, ordinarily, sound hits the drum, pushes the malleus, incus, and stapes into the oval window, right? And when the oval window is pushed inward, the round window bulges. Okay, those who indulge, bulge, my mother used to say. Well, when I'm pushing in on this fluid, it's going around the cochlea, and then fluid will bulge the round window, much like my cheek going. So every time the oval window pushes in, and I'll stop sharing. I want people to get this. When the oval window pushes in, the round window, okay? And if the round window can bulge, that allows the oval window to push in. You always have that trading of action constantly, which creates tiny little ripples that take place inside your inner ear. And that causes you to hear. Those little ripples, we will learn later, are called traveling waves. So again, but if the round window cannot bulge, let's say we held that thing still, put a thumb on it and stopped it from bulging completely. If we did that, okay, then let's just read this. The oval window pushed inward bulges the round window. The round window, if we pushed it inward, would bulge the oval window. Energy to the oval and round windows simultaneously, however, at the same time, you haven't got that interaction anymore. And the cochlea won't be activated with 30 to 35 dB inputs, and a conductive loss can therefore be more. 60 with circumoral headphones. TDH39 is the name of the headphone used in audiometry. So what can make this happen? Various middle ear pathologies, such as missing ossicles or otitis media, middle ear infection. Oto, ear, itis, inflammation, media, middle. OM, otitis media. Let's look at that. Okay? Woo. All right. So if the round window cannot bulge, if this is held stiff, because this whole area, you see my cursor? Pretend that's filled with pus. The child has a middle ear infection, and this is totally filled with pus. And if that's totally, this trade-off interaction can't occur. And if that trade-off interaction can't occur, well, then it doesn't matter about these three elements. Those aren't going to occur either, of course. But your hearing loss will then be worse than 30 to 35 dB. So your hearing loss can be much greater. Now, here is the resonances of your middle ear. And you can see around 1,000, 2,000, you can see that there's a lot of resonance offered by the middle ear. In fact, the middle ear ossicles, the little bones of the middle ear, resonate with frequencies around 2,000 hertz. This has a resonance around 2,000 hertz. Okay? And that's what's being shown here. And then, when you look at the resonances of the outer ear, we covered that a couple of weeks ago. Your outer ear canal also has a resonance. And when you put these two resonances together, the middle ear and the outer ear, guess what you get? a smile. And in English, that means this. We hear these general frequencies, and I'll just put it in good old biblical terms. Matthew, Mark, Luke, and John. 500, 1,000, 2,000, and 4,000 hertz. We hear those the best. Look at this. Fewest decibels are required to hear them. Okay? Our best hearing is naturally between 1 and 4,000 hertz. Right there. Look at the sweet spot. Look where the smile goes down the most, and look at the corresponding decibels to just barely hear. So in dBSPL, we hear those frequencies the best. Why? Because of the resonances of the outer ear and the resonances of the middle ear. And when you think of resonance, think very simply of a wine glass at Christmas. And your middle ear and outer ear have that shape precisely because of those resonances that are desired. And you want those resonances because those are the resonances of high frequency speech. So here it's showing you my way. Outer ear canal and concha, middle ear, put this plus this, gives you uneven hearing across the frequencies. And MAF just means with both ears. MAP just means with one ear under a headphone. Okay, one ear under a headphone, the white line. 2 ears in front of a speaker, the yellow line. And why the little bulge here? Because when you're plugging up an ear with a headphone, you've lost this. You've plugged it up. Okay? So, but at any rate, MAP means minimal audible pressure. You'll learn more about that in 110 later on. MAF means minimal audible field. You'll learn more about that in 110 later on. Okay, I always cross the courses. I always throw things in to make sense, but basically the thing to take home right from here in 120 anatomy is your outer ear. It has its shape precisely because it gives you the resonances in the high frequencies. And the middle ear has its resonances because of the tiny little bones. And both of these serve to give you best hearing in the high frequencies, and that's where the letters S, S, Sh, T, K, consonants, the high pitches of sounds that elderly people are missing, which is why we have a field called hearing instrument sciences. Okay, you've got these things for reasons. So, all right, there we go. Now we're going to move on and look at the top of, I believe it is page 3 in our notes. Yep, page 3. So we've talked about this top point. Maximum conductive hearing loss can be greater than what the middle ear adds, and you now know why. Here's something you may want to put a star by, okay? The maximum measurable conductive hearing loss, and always remember what conductive hearing loss is. Hearing loss that results from a blockage of sound getting to the inner ear. Problems with the outer ear, problems with the middle ear, those both cause conductive hearing loss. Problems with the inner ear causes sensorineural hearing loss. Different kettle of fish. 95% of people have sensorineural hearing loss. Elderly people, presbycusis, okay? Presbyterian, Church of the Elders, presbyopia, your arms aren't long enough to reach the page. Presbycusis, hearing loss in the elderly. And what is that? Treble hearing loss. Trouble hearing treble. Anyway, a little known fact is that the maximum conductive hearing loss possible that you can measure in audiometry in 130 depends on the headphone. Okay, circumoral headphones, the biggest conductive hearing loss you can measure, 60. Insert headphones, the biggest conductive hearing loss you can measure, 75. Okay? We'll get more on that later. This point here, resonances of the middle ear, ossicles, 2,000 hertz. Okay? Don't worry so much about these guys. The resonances summary, the middle ear adds about 25 to 35 dB, especially between 5 and 5,000 hertz. The outer ear, it adds about 20 to 25 dB between 1,500 and 4,000 hertz. And that's where you saw when I showed you these pictures here. Okay, outer ear adds this, about 20 to 25 dB. Middle ear adds this, and this plus this gives you these curves. Okay, very good. All right, look at these acoustic reflex. What we're doing now, whoops, not that, I don't want Skype. Okay, acoustic reflexes. Now, let's look at what those are. What the heck is a reflex? The acoustic reflexes. Reflex action is something that you do automatically without looking, right? Have your legs crossed, a doctor taps your knee with a hammer, your foot shoots out, okay? Put your hand on a hot stove, okay, it's a reflex. It didn't go all the way up to your brain, you just immediately, okay? A reflex is something that happens when the message goes from your limbs or from your legs to your spinal cord and right back out again. It doesn't go to your brain, okay? I'm not sitting there thinking with my hand on a hot stove, I should probably remove my hand or my skin will scald. No, 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 it's just, the message went right to my spinal cord and right back out to my muscle to pull away. A reflex is exactly that. The message goes to a primitive part of your brain and back out. Now, when you think about your brain has a tail, and the tail goes all the way down to your bum, and that's called your spinal cord. Okay? So your brain and the spinal cord continues out of your brain and goes all the way down your back. That's all what they call the central nervous system. And messages that go from your limbs to that central system and back out again are called reflexes. Okay, now reflexes you don't have to think about, they just happen fast. And when you think about the brain called the brain stem is your spinal cord inside your skull. Okay, so your spinal cord, once it enters your skull, it's called your brain stem. How long is your brain stem? About an inch. Okay, how big is your brain stem? About like my pinky, what I'm showing you here. Okay, it's small. Cut it and you're dead. Okay, so all important, don't do that. Okay, but messages go into your brain stem and back out, same thing. Those are reflexes. Okay, so the acoustic reflex, let's talk about it. What the Sam scratch is the acoustic reflex? It has two muscles, the tensor tympani and the stapedius muscle. So look at the tensor tympani muscle. Here's the muscle. Here's your stapedius muscle. It's attached to the neck of your stapes. It's attached to the neck of the stapes bone. And the other muscle is called your tensor tympani muscle, and it's attached to the malleus. Okay, so one muscle attached to the malleus, the other one's attached to the stapes. When those two muscles pull, they make the whole middle ear system tight. Okay, in other words, they make the middle ear not work as good. And it's that they happen for a reason. Okay, so when they tighten, they make the eardrum tighter than it normally is, and they pull the stapes out of the oval window, thus making the middle ear not work quite as well. That's the acoustic reflex. Our question here is, why do we have an acoustic reflex? And let's just talk about that for us. Why would you have that? Now, have you ever listened to your voice on a recording? And you listen to your voice on a recording and you go, ugh, that's me. And everybody says, yeah, that sounds exactly like you. You're the only one who hates it. Everyone else says, yeah, that sounds exactly like you. You ever experienced that? I have. I hate to be you, because when I listen to my voice, I hate it on a recording. You hear me differently than I hear me. Okay, look at this. We hear other people through air only. The sound waves from your voices reaches my ears. That's called air conduction, right? So I hear you through air conduction, but I hear myself through air and through bone, both. Okay, so we hear ourselves through a combination of air-conducted sound and bone-conducted sounds. And what is the skull mainly? Mass. And what does mass resonate with? Lows. So we hear ourselves more richly, more rounded, and louder. What's the average intensity of conversational speech? About 65 decibels, SPL. You'll learn that more in acoustics. About 65 dB SPL. Okay, sound pendulum. Average conversational speech. My father can beat your father at checkers. Yakety, 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 yak. Average yakety, yak, talking speech, walking down the hallway. 65. We hear ourselves talk at around 85. Because we hear ourselves not only through air, but also through bone. And the acoustic reflex kicks in when we talk. Why? To make the sound of our own voices a little bit softer while we talk, so we can hear others speaking better. The acoustic reflex, weird. It's also a bit of a protection against loud sounds. Let's look at it. Share screen here. Here's the location of the Stapedius muscle, and here is the location of the Tensor tympani muscle. Okay? Now, many people draw this weirdly. I'm going to get out of here and go into our writing. Let's read what it says here. Tensor tympani muscle and Stapedius muscle. The Stapedius muscle is smallest, but it's strongest. And these are innervated. What it means that they are fed messages by nerves. And there's two nerves. One goes to the tensor tympani muscle, the other one goes to the Stapedius muscle. You have 12 pairs of cranial nerves in your head. Off of your brainstem, that 1-inch long thing, okay, your spinal cord inside your skull, there's 12 pairs of nerves coming off of it. 1 pair, 2 pair, like a fork. Okay, the bottom pair is for the eyes, optic nerve. Several nerves are for your tongue. Okay, so one nerve is for smell, another nerve is for hearing. Okay, the eighth cranial nerve, the 8th pair, okay, that's for hearing. But there's two other, how many fingers, Ted? There's 2 other nerves, cranial nerves, that come off that are also dealing with hearing, and that's the 5th and the 7th. Okay, the 8th is for hearing. If you cut the 8th nerve, you're deaf. Okay, so we have 1/8 nerve on the right, of course, 1/8 nerve on the left, and the 8th nerve goes from the cochlea, from the inner ear to your brainstem. And if you cut that puppy, you're deaf. Okay, you have one from the right ear, one from the left, but you have 2 5th cranial nerves and you have 2 7th cranial nerves. So let's look at what they do. They feed the acoustic reflex. So the 5th cranial nerve goes to the tensor tympani muscle. And the Stapedius nerve, it's innervated, or it's connected to the 7th cranial nerve. In Roman numerals, the V is 5, and in Roman numerals, a VII is 7. Okay, so Stapedius is innervated by the 7th facial nerve. Tensor tympani is innervated by the 5th, or what they call the trigeminal nerve. And here's your acoustic reflex arc. It includes an afferent, brain-going direction, and an efferent, back-to-ear direction, right? I mean, if you put your hand on a hot stove, the message of heat's going to go up your arm to your spinal cord. That's afferent. That's going to the brain, and then the reaction to pull away, okay, that goes from your spinal cord to your muscle. Pull away. So you've got to and fro, right? It's not a one-way street. Messages go to your brain and back out. So stimulus, response. So hand on hot stove, okay, the heat sensation up my arm, and then the message to pull away, okay, goes back to my muscle saying pull away. That's an arc, a loop. One goes to, one goes back. Afferent means to the brain. Efferent means from brain back to the muscle. Good. You got it? Getting it? Let's look at the acoustic reflex arc. It has a loop as well. Now this is a weird looking picture. FNO, freak not out. Let me take you through it. It just looks weird, okay? Outer ear canal, middle ear bones. I know they don't know how to draw bones very well, okay? Middle ear bone. And this little beehive would be called the cochlea or inner ear. And that message goes to the 8th nerve. This is your 8th nerve. And then this whole area here is called brainstem. And then the messages go back out to the tensor tympani and back out to the stapedius muscles to pull, acoustic reflex. And if you make a loud sound in one ear, you're going to have the reflex occur in both. Because once messages hit your brain stem, the proverbial shit hits the fan. That's when all things cross over. Okay, so a loud sound to one ear is going to cause an acoustic reflex in both ears. Sounds that are about 85 decibels or louder will cause an acoustic reflex. Now, this is a boring drawing. Here's a picture I drew of it, just about as boring. Okay, but here's the loud sound, outer ear. Here's your afferent root. Outer ear, middle ear, cochlea or inner ear. You can see the arrow. 8th nerve going to the brain stem, and then see these light gray arrows. That's efferent. Message going here to your tensor tympani, message going down the 7th nerve to your stapedius muscle. So a loud sound in one ear is going to cause an acoustic reflex in both ears. That's why I drew both ears here, one on the left and one on the right. And I just said loud sound in the ear canal, eardrum, middle ear, cochlea, 8th nerve, brain stem, and then back out to pull on those two muscles. That's the acoustic reflex arc. Okay, enough on that. Let's read it here. We'll just read now. Because I talked a lot, and now let's just read the notes and see if they're consistent with what I was saying. Okay? Acoustic reflex arc includes afferent, brain going, and efferent, back to ear direction. Afferent, middle ear to cochlea to 8th nerve to brainstem. Lots of crossover. And the word used in our field is decussation, crossover messages. Efferent means 5th cranial nerve back to the tensor tympani muscle, 7th cranial nerve back to the stapedius muscle. That's the acoustic reflex. Acoustic reflexes occur in both ears, even though one ear is stimulated. Why? Because of that crossover. The acoustic reflex is caused by tones that are over 80 decibels, also by chewing, also by one's own speech. So when you're sitting there in front of TV and you're chewing a bag of chips, okay, you're going to have the acoustic reflex kicking in. Many people complain about having difficulty hearing while watching TV. Well, if you're chewing a bag of chips, no kidding, okay? A, the loud noise is going to mask what you want to hear, but B, chewing is going to cause the acoustic reflex. There's something to think about. Anyway, share a screen, keep reading. Acoustic reflexes, how much do they decrease sound by? About 5 to 10 dB, about. And they are strongest for the low frequencies. And that means if a loud low frequency sound comes in, you're going to have an acoustic reflex. But if a loud high frequency sound comes in, you won't have much of one. And you know why? Because the vowels of your own speech are louder and lower. So what's the loud parts of your speech? The low frequencies, not the highs. I mean, think about it. And you've heard this before, but let's make sure we get this. If we say the word call, as in call, what's the loudest part of that word? Ah. The k isn't very loud. If we say the word church, church, what's the loudest part of the word church? We say the word speech, speech, e. That's the vowel. Anything that you have your hand to your throat and it vibrates is louder and lower. But if you say the letter F, it's not very loud. S, K, consonants, high-pitched, okay? And that's what elderly people are missing. They can't hear the consonants. They've got trouble hearing treble. That's why they say young people mumble, okay? They hear the loud, they can't hear the soft, high-frequency consonants. So the loudest parts of speech are your vowels, and that's what the acoustic reflex dampens. That's what the acoustic reflex blocks out the most. Loud, low-frequency sounds. Okay, if we go move on down, look at this, common misconception. Acoustic reflex is nature's protection against noise exposure. Not really true. It reduces the loudness of your own voice while speaking. Recall from acoustics, and you will get this more in acoustics later as well. Low frequency vowels are louder than high frequency consonants. Average conversational speech heard from others by air conduction is about 65 dB SPL. Our own voices is much louder because we hear ourselves by both air and bone conduction together. And that's enough to cause an acoustic reflex. Recall, the acoustic reflex is strongest for low frequencies because the lows of our own voices contribute most to the loudness of our voices. So basically, we have now completed the physiology of the middle ear. In other words, how it works. Last week we looked at the anatomy of the middle ear, the pieces and the parts, and we started in the physiology. Okay, we talked about the 3 ways that the middle ear overcomes the impedance mismatch. Size of eardrum compared to size of stapes. Leverage action of the middle ear ossicles, buckling action of the eardrum. Those 3 combine to increase pressure by 44 to 1, which corresponds to a 30 to 35 decibel increase. That's physiology. Again, how it works. Then we looked at the acoustic reflex today, and we basically went over what that is and what it's for. And now, having covered that, we'll give a brief overview of some disorders of the middle ear. Now, this summer, you're going to have a course called Disorders 125. Okay, so we'll be going over all of this again in the summer. And I believe you'll suffer the misfortune of having me for that course, because usually I teach 125 hearing disorders. Happens in the summertime. I think it's one of only 2 courses you take in the summer. Anyway, disorders of the middle ear. The numero uno is otitis media. Children, earaches. Okay, and let's look at why. When you look at kids, children have shorter faces, okay? Let's look at this picture here. Here's a little kid. Children's faces are shorter. And because children's faces are shorter, the tube going from the middle ear to the tonsils is more horizontal. Now, we've all had it when we blow our nose real hard, you feel it up in your ears. Okay, that's your eustachian tubes. This is the eustachian tube. Now, in adults, the face, here's an adult skull, it's longer. Adult faces are longer. And so in terms of eustachian tubes, adults' eustachian tubes are more vertical. Children's eustachian tubes are more horizontal. And that's why infection crawls up a child's eustachian tube more easily than it does in adulthood. We tend, not all of us, but most of us, we grew out of earaches when we hit puberty. When our faces got longer, okay? And so adults don't tend to get otitis media as much anymore. Just food for thought, just telling you, okay? So otitis media, it begins as stages, like chapters of a book. Chapter 1, sore throat, upper respiratory infection. Now you've got your tonsils are swollen. And now your eustachian tubes won't open when you swallow. Remember we always said eustachian tubes are kind of like government offices, closed unless forced open. Okay? So eustachian tubes are normally closed, and they open when you yawn, they open when you swallow, they open if you blow your nose real hard. Okay? And they're supposed to. You need that, because when they open, they let new air into your middle ear space. And your middle ear space needs that, because your middle ear space is always absorbing oxygen. So new air has to get up into that middle ear space every now and then. So when you yawn or you swallow or whatever, the eustachian tubes open for a split second, letting new air in. If you've got a sore throat and your tonsils are swollen, your eustachian tubes don't open anymore when you swallow because they're swollen shut. And meanwhile, that middle ear space keeps absorbing oxygen. So now the eardrum gets sucked in, gets negative air pressure in your middle ear space. That's called an earache. That causes an earache. That's when the kid says, "Mommy, my ear hurts." Okay? So now your eardrum is sucked inward because there's a vacuum. So chapter 1, sore throat, tonsils swollen. Chapter 2, negative middle ear pressure because your eustachian tubes aren't opening anymore. Chapter 3, okay, let's look at your Microsoft Word here. So now you've got, here's chapter 2, vacuum results in closed middle ear space. Tympanic membrane is sucked inward, pain. And chapter 3, now your middle ear begins to bulge because it produces fluid. And the fluid is a reaction against the vacuum. So here's a normal middle ear or a normal eardrum. You're looking at the eardrum, down the tube, down the ear canal, and a normal looking eardrum. And here's a retracted eardrum. Due to early otitis media, you've got that vacuum in the middle ear space, sucking the eardrum back. And you can see the whole eardrum is laying on the promontory, the bone between the oval window and the round window. And here now, you've got fluid behind the eardrum, because now your body has reacted against the vacuum, and now fluid is building up in the middle ear space. Now the middle ear space normally just has air. Okay, now your whole middle ear space is filled with fluid. And this is called serous otitis media. It's like the fluid under a blister. Clear, uninfected, clear fluid. But it's not long before that clear fluid turns into pus. And now it's white. And look at this bulging eardrum. You can see the umbo in the center, but it's the serous otitis media has changed into acute bulging otitis media. And now, Houston, you got a problem. Okay, it's time to go to the doctor and get on antibiotics or get some treatment for this, because This will cause more than what the middle ear makes up. We said the middle ear naturally adds about 30 to 35 dB. Well, this child here probably has a 60 decibel conductive hearing loss because the oval window can't push in and the round window can't bulge. You've got none of that trading action because the whole middle ear space is filled with pus. I mean, think about it. This whole space here is white. It's just blocked. So no pushing in of the oval window can't result in a bulging out of the round window. Ain't gonna happen. Many times the treatment for otitis media is puncturing the eardrum and putting in a tube. And the tube has a little hole in it. And that allows the air pressure to remain even Steven. That allows new air to get into the middle ear space. And this is one, they call this a pressure equalizing tube. It allows air to communicate. If the back door doesn't open, well then what the heck, let's use the front door. If the eustachian tubes are constantly plugged due to constant colds and swollen sore throats, and the child has recurring bouts of otitis media again and again and again, well then we've got to fix that, and a non-medicinal way to fix that with no antibiotics is the use of pressure equalizing tubes. And these tubes grow out. They eventually fall out of the ear. Okay, they don't stay in there more than a couple of months because your skin migrates outward. And eventually that tube will just fall out into the ear canal. It's just a tiny little thing, okay? So here's a hearing loss often seen in otitis media. And I'm just giving you a heads up. This is preview. You're going to learn about this in audiometry in 130. You're also going to see this in hearing disorders this summer, 125, okay? But here's the O's are the right ear, and the X's are the left ear. Now, if you're looking across here, this is frequency. So low 125 hertz, 250 hertz, 500, 1,000, 2,004, and 8. Now, the vowels are down in the low frequencies. The high frequency consonants are toward the right. So bass is on the left, treble is on the right, and the numbers going down are decibels from -10 to 120. Hey, Shabana, remember seeing that for a couple hours ago, 120 decibels? Well, there you go. Told you. So here you go. So here we got the child can't hear until it's about 40 or 50 decibels. The child has hearing loss all the way across because he's got an ear infection, otitis media. But when you take off the headphones, take them off and put that headband on the child's ear, and there's a box on the headband, and it lays on the mastoid bone, and you deliver sound through the mastoid bone. When you do that, the kid hears like a baby. Look at this. Never takes more than 5 decibels for the child to hear. So when you're bypassing the outer ear and bypassing the infected middle ear, the child's inner ear is picking up the sound no problemo. Good. That's what you want. They call this in audiometry an air-bone gap. The child has hearing loss by air conduction. The O's are the right ear headphone. The X's are the left ear headphone. So the child has like a 40 or 50 decibel hearing loss through headphones, but by bone conduction, the hearing is normal. And that is what you call a conductive hearing loss. C-O-N-D-U-C-T-I-V-E, conductive hearing loss. Much as electricity is conducted through a wire, sound is conducted through the ear. Okay, so conductive hearing loss is a mechanical blockage of sound from getting to the inner ear. And that mechanical blockage can be wax in the outer ear or infection in the middle ear. Otitis media, the most common middle ear pathology in the book. Okay, that's a big one. Here's another one. This person here has what they call cholesteatoma. It's a tumor growing behind the eardrum. This is an eardrum, and there's a tumor growing behind the eardrum. It happens because the child got otitis media so many times, and the hole in the eardrum is kind of like a letter D. See where my cursor is doing? It's at the edge of the eardrum, and that hole doesn't heal, and the skin starts to create tumor-like cells in a desperate attempt to close the hole, and it can't do it, and so a tumor grows behind the eardrum. That's got to be taken out immediately by a doctor, because the middle ear space, let's just show you the middle ear space again. Let's just go all the way home here. The middle ear space is 1/8 of an inch from the bottom of the brain. So middle ear pathology, left untreated, can infect the bone around the middle ear space, and that's called mastoiditis. Mastoid bone itis inflammation. And when it gets to mastoiditis, antibiotics won't help. They have to do surgery and take away that bone. And they often remove the middle ear ossicles as well. It's called a mastoidectomy. The person's left with a permanent conductive hearing loss. But they do that to prevent meningitis. Because if the brain gets infected, you'll take a dirt nap, also known as dying. Okay? So you can't have that. And that's why I said in the notes, you had these stages. Look at this, 1 through 6. Okay? So read the stages. Sore throat, vacuum in middle ear space, uninfected serous fluid. Serous fluid turns into pus. That can turn into mastoiditis if not treated, and can result in meningitis if not treated. Treatment for otitis media, antibiotics, pressure equalizing tubes, tonsillectomy. Yeah, there's a few of us who are old enough to remember getting tonsillectomy, okay? Many people don't get tonsillectomies today, but many people 50 and older remember very well tonsillectomy. And it was done, and it's coming back in fashion, by the way, because we are becoming immune to our own antibiotics. And there's a few other pathologies of the middle ear. Otosclerosis, just for the heck of it, I'm going to just show you a picture of otosclerosis if I've got it. We'll go down here a little piece. Otosclerosis, eh? Oh yeah, here's a picture of otosclerosis. It's a soft, porous, bony growth around the footplate of the stapes. It is hereditary. Okay, if mom or dad has it, chances are one of the kids is going to have it. It hits in early adulthood, in your 20s. More common in women than in men, and it also creates a conductive hearing loss. And treatment for otosclerosis is often a stapedectomy. You can see where they removed the stapes, and they put in a prosthesis and a new oval window. Original, and everything is all gummed up by this bone here, the soft, porous growth of bone, which seizes up the whole middle ear space. A stapedectomy is often done to alleviate the condition. Some people don't go for a stapedectomy. They just say, just simply give me hearing aids. I'll wear hearing aids. So stapedectomy is one approach used for otosclerosis. And see here, you can read it. Middle ear ossicles lose calcium, become soft. Sclerosis is really not an accurate term, but it should be called otoporosis, actually like osteoporosis, but of the ear. Anyway, middle ear function is compromised, very hereditary. Treatment for otosclerosis, stapedectomy, hearing aids. Cholesteatoma we talked about. And the last one here, patulous or patent eustachian tubes. Now that's when the eustachian tubes, instead of being closed, they're mostly open. So this eustachian tube going down to the throat doesn't close. And that's going to happen in people who've lost too much weight in too quick a time. Women on crash diets, anorexia, bulimia. Same with cancer treatment. People who are on chemotherapy for cancer and they've lost an awful lot of weight. And what's going to happen in those people, they don't have enough tissue left in the eustachian tube to keep it closed. It's always open. And so it's not closed unless you yawn or whatever, or swallow. It's always open. And then you hear yourself really loudly, as if in a barrel, because the sound from your voice is going straight up into your middle ears. And so the people then complain about hearing themselves very, very loud. Constantly open eustachian tubes due to extreme weight loss. Voice sounds like you're inside of a barrel, hollow. Here's how we end. Problems of the outer or middle ears result in conductive hearing loss. Sound conducted via air has problems getting to the cochlea. A conduction problem, a lot like light not being focused properly on the retina of the eye. You can think about conductive hearing loss as a plug in the ear. When you wear earplugs to protect yourself from noise, you're giving yourself a conductive hearing loss on purpose. Okay, you want to not hear the noise. So if you're wearing earplugs as noise protection, you're giving yourself a conductive hearing loss for a temporary time, on purpose, deliberately. Think of a conductive hearing loss like a plug in the ear. You can't hear soft sounds and also loud sounds. Bring them on, buddy, because I got a blockage. Okay? Sensory neural hearing loss is so different. Elderly people with a hearing loss, they can't hear soft sounds, but you yell in their ears and they're going to punch you in the head. Okay? 100 dB is going to hurt them just as much as 100 dB hurts a normal hearing person. Loud sounds are just as loud to someone with hearing loss. It's like the ceiling of loudness tolerance didn't change. The floor just went up. They couldn't hear soft sounds. Okay, it's like their feet aren't on the ground anymore. Now they're standing on a table. But yet the ceiling didn't get any higher. Their dynamic range is smaller. Okay? But conductive hearing loss is like both the floor and the ceiling went up together. Okay, I can't hear, but I can also tolerate loud sounds because I've got a plug in my ear. So that's the general way to break hearing loss down into its two main components: conductive hearing loss, sensory neural hearing loss. 5% of people have conductive hearing loss, 95% of people have sensory neural. So where's the damage in sensory neural? The cochlea, the inner ear. And that's where we go next. Any questions so far? How are we all doing?
So I have a question.
Yeah.
I had the gastro bypass surgery, so that means I could lose hearing?
You've had what bypass?
The gastro bypass, where I lost weight. I lost 165 pounds in a year.
Okay, now I don't think so, because otherwise you'd be hearing yourself. If you had problems with your eustachian tubes because they were always open because you lost weight too fast, you'd be hearing yourself really loudly and you'd be complaining about that bitterly. My suspicion from listening to you, I don't think that's going to affect your hearing at all.
Okay.
Not at all.
Yeah, I have a quick question.
Yes.
So when they do the operation for the stapedectomy,
yep.
Where do they go to access that? Like, how would a surgeon access it?
They slice behind the ear and fold the ear open.
Oh, okay.
Yep. And the nice thing is, you can't see the scar because it's right behind the ear. So there's no one would even know you had it done.
Right.
Yeah.
Okay, thanks.
All right, so remember from this particular unit and last week's unit, okay? Remember the pieces and parts of the middle ear, the bones, the oval window, the round window, the promontory in between, the malleus, incus, stapes. Remember the acoustic reflex, the two muscles. Remember the nerves that connect to each of the muscles. Remember the three ways that the middle ear overcomes the impedance mismatch between air and fluid. Okay, remember, I promise I'm going to ask that. Promise. You will be asked, how much does the eardrum versus the stapes? 17-1. What's the leverage action of the middle ear ossicles? What does that add? 1.3-1. What's the buckling action of the eardrum do? That adds a pressure increase of 2-1. Put it all together, a pressure increase of 44-1. What does that correspond to in decibels? 30-35. Why can a conductive hearing loss be more than 30-35? Because when you block that interaction between the oval and round windows moving, because you've got pus gumming up the middle ear, you will indeed have a hearing loss more than 30-35 dB. Okay? These are the basic tenets, the basic knowledge pieces we need to know about the middle ear section, unit 3 in anatomy. Okay? So we spent 2 weeks on the middle ear, and we will move into the inner ear. We'll spend 4 weeks on the inner ear, because that's where the proverbial crap hits the fan. That's the holy of holies. That's the inner sanctum. The outer ear and middle ears are just means to an end. They help sound get to the cochlea. But always remember, it's the cochlea that is to the ear what the retina is to the eyes. And when you think of the eyeball, okay, the lens just lets light in. The pupil lets light in. But light has to hit the back of that eye. And the back of the eyeball is called the retina. And that changes light into electricity. And that's what your brain runs on. Well, the cochlea changes sound into electricity. So the cochlea is literally the retina, in quotes, of the ear. And in vision loss, almost nobody has retinal damage. Almost everybody has problems with light getting to the retina. So 95% of vision loss is conductive vision loss. It's exactly the back-asswards in our field. Only 5% of hearing loss is conductive in nature. 95% is like me going to the back of your eyes going, now go ahead and wear your glasses. How do you like me now? Okay? Damage to the retina itself. And the retina, it's in quotes, of the ear is the cochlea. And that's where elderly people have problems. That's where noise-induced hearing loss, cochlea. Age, cochlea. Drugs that cause hearing loss, cochlea. It's always the cochlea, okay? And that's why you can't fix cochlear problems. You can't do surgery on a cochlea. And that's why you have a profession. If they could do surgery, they'd fix it. The fact is you can't fix cochlear hearing loss. You can fix middle ear pathology. You can fix outer ear pathology, okay? But you can't fix cochlear pathology. That's why HIS is field, because you can't fix it. That's why we have a 2-year college program, okay? All right. I should take this out, put it on the stove for a while, or put it on ice. Okay, I'm really glad we've had people showing up for this session. I think the Zoom sessions, and spread it around if others don't know, but I'm telling you, I've had students going, should we watch those? And I'm kind of going, no shit, Sherlock, because you are missing the entire picture if you don't. You can read all you want, and it's all good, but if you really want the condensed stuff, do it here. And if you can't access them live, who cares? Doesn't matter. I always record. All right. Live long and prosper. We'll see you next week. I'll send, and next week our Zoom session is going to have to be on the Monday. Tuesday I will not be in town, but I will send everybody an email to remind. Okay? Always check your OTC emails once a day. I may not send anything for a week, and then all of a sudden one day you'll get 3 emails. So it's just a good idea to check it just once a day. Check just to see if something comes in. Okay?
I have another question. This isn't concerned to this class, but the Acoustics 110.
Yes.
Is there any way that we can get you to the math parts on giving us more of a layout on it? Because
Well, I'll tell you,
very confusing.
I'm working with Ms. Royer on that because we've had some people ask about that. You're not the only one, but I will tell you this, Lisa, just so you know, there's in Unit 1, I'm showing 2 fingers, in Unit 1, there's only 2 formulas to know. One it's frequency is 1 over period, period is 1 over frequency.
But I mean,
Okay.
like on some of the questions that were asked, though, I didn't know how to figure that part out. Where am I getting these numbers from?
And it's just, if I'm showing you a sound wave on the bottom and it's got a period on it, let's say if the period is 0.001 seconds, okay? Well, frequency is 1 over period. Frequency is 1 divided by 0.001. Hit your calculator, you'll get 1,000. Done. Slain and pimple. Yeah, and then if you see another wave beside it, and it's also got 0.001 seconds, but there's 3 waves in it, you don't even need to do the math. You can just look at that and go, huh, well, that's 3,000. Because if the one on the left was 1,000, this one's got 3 bumps in it. And then the one on the right's got 4 bumps. Well, shit, that's 4,000. Because you had the same length of time, but you had 4 bumps instead of 1. The second formula to care about is the physical length of the wave, not the period, not the time it takes to complete one wave, but the physical length of the wave. And that always is this. Wavelength is speed of sound divided by frequency. So wavelength, let's do 500 hertz. Wavelength is 340 meters per second divided by 500. Hit the calculator. So let's see, 340 divided by 500, 0.68 meters. Done. Done. Or you can do it in feet. Wavelength is speed of sound over frequency, 1,130 feet per second. Okay, I'm going to make that up. 1,130 divided by 500 hertz, as an example, equals 2.26 feet. There you go. So try not to make it more complicated than it needs to be. But I will talk to Ms. Royer about throwing you out an assignment of some practice questions. Okay. And that way, and then with some answers. Okay?
I think that'll help a lot.
Good stuff. All right.
Thank you.
Okay, you're most welcome. I'll hit stop recording here and sign off here.